Good morning, good afternoon, and good evening. We are delighted to have you join us today to announce and celebrate our Serena Bright Contrast-Enhanced Guided Biopsy. We first shared our intention to provide this industry-first innovation with you last year at RSNA, and today we are so proud to share with you that the product, Serena Bright, is here. As you all know, the best defense against breast cancer is early detection. Matter of fact, in our current environment, it is more important than ever to ensure women don't skip their mammogram. GE Healthcare is committed to innovation that can help engage more women in breast cancer screening. Solutions like contrast-enhanced mammography can provide answers sooner for the patient, which can lead to faster care plans being implemented, and also confidence that the patient can go back into routine screening. The contrast-enhanced journey at GE Healthcare started 11 years ago when we first brought to market Bright contrast-enhanced spectrum mammography. Since then, we've continued to innovate, and also we continue to improve our image quality. With Bright HD, and other companies have joined us in offering this important tool radiologists can use to identify hidden lesions. But let me ask a question. What was happening when a lesion was located with CSM? A patient would need to be biopsied under other imaging methods where lesions could be difficult to locate again. Scheduling for an MRI-guided biopsy could be pushed out several weeks, and potentially the biopsy could be more costly to both to the patient and to the facility. But today we provide you the complete CSM platform by adding the ability to biopsy a lesion with contrast-enhanced guidance. We partnered with several forward-thinking, innovative breast radiologists who will share with you today how this technology is changing their patient care, and also how this technology is helping diagnose the most difficult cases. You'll have the chance to see a case, and we encourage all of you to submit questions via chat throughout the panel discussion and the case review. I am just so proud of the work our team has done and truly honored to work with dedicated breast colleagues. And without further ado, I will turn it over to our panelists, Dr. Rodrigo Alcantara, Dr. Anat Kornecki, and Dr. Corinne Balleyguier, and our moderator, Dr. Jessica Leung. Thank you.
Thank you, Agnes, for the introduction, and thank you all for joining us today. My name is Dr. Jessica Leung. I am a breast radiologist and deputy chair of the Department of Breast Imaging at MD Anderson Cancer Center in Houston, in the United States. I will be joined today by three of my peers who are breast imaging experts from across the globe. I will introduce them to you shortly. Before we begin, I would like to cover a few housekeeping items regarding the platform we are using today. If you would like to see all four speakers on your computer screen at once, and currently do not, please switch your view to the side-by-side view, which is located in the upper right-hand corner of your screen. This webinar is being streamed, so volume can be adjusted directly from the speaker control panel on your computer. If you have any questions during the event, please submit them through the question and answer, the Q&A widget, which is found on your computer screen. We will try to answer as many questions as we can at the end of the case review. Now with that, I'd like to welcome Dr. Rodrigo Alcantara from Hospital Del Mar in Barcelona, Spain, Dr. Anat Kornecki with St. Joseph Hospital in Ontario, Canada, and Dr. Corinne Balleyguier from Gustave Roussy in Paris, France. We're here today to celebrate and to discuss bringing contrast-enhanced guided biopsy to the market. All of you have been proponents of contrast-enhanced mammography and now have had the opportunity to work with the complete platform by adding contrast-enhanced guided biopsy to your practice. But before we dive into contrast-enhanced guided biopsy, can each of you please share a little about your programs and the types of patients you see in whom contrast-enhanced mammography helps the most? Let's start with Dr. Alcantara. Can you please share with us, in your experience, in which patients is CESM most useful clinically?
Thanks. We use CSM for many reasons, actually, but mainly for symptomatic patients in a fast diagnostic circuit, for example, and also has a problem-solving tool for standard routine mammograms and some recalls from the breast screening program. Recently, we are starting to consider it as an alternative for selected cases of neoadjuvant chemo, and of course, since the beginning, it's more than welcome for all those women that have contraindications for MRI guidance.
Sounds like you have a fairly extensive list of diagnostic indications for your patients. Dr. Balleyguier, are you using CESM for any other types of patients?
We do exactly like presented Dr. Alcantara. So most for organization purpose in our one-stop diagnosis, because we developed this special visit since more than 15 years now, with at least 25 new patients every Monday, and we do everything in one day. It's a post-screening day, and in this case, with for fast organizations, instead of performing an MRI in non-conclusive patients, or also in breast cancer staging, we use more and more contrast mammography, and I would say that this is very useful to have all these complete diagnostic possibilities during the same day by the same radiologist. So there is a unity of diagnosis, and which is really helpful for quality.
It sounds like too that you're similar in practice to Dr. Alcantara, and that it kind of serves as another contrast study similar to what we've been using for MRI. Is that about correct?
Yes, in many cases, instead of performing an MRI for indications of MRI for breast cancer staging, we replace MRI with contrast mammography, and I would say it's very useful and very easy to interpret. We have only 4 to 5 views to interpret instead of 4,000, even 5,000 images for MRI, and it could help to give the diagnosis with a very safe way and very easy way. And also this is very useful for clinicians, clinicians, surgeons, oncologists, radiation therapists also like this technique, because maybe it's easier for them to evaluate their patients instead of complicated MRI.
Those are great points, right? That is faster, less images, more as something that our clinicians can take their hands on and understand because of the easy representation that is accessible, and of course costs, which I'm guessing is shared by all of us in our various countries. Now, Dr. Kornecki, are you doing anything different in your practice than the 2 panelists that already spoken?
Our practice is very similar. We decided to offer contrast-enhanced mammography to all patients that are being diagnosed with cancer, unless they're completely fatally replaced. And it actually was driven by the oncologist and surgeon. It is easier way for them to communicate the findings to the patient, and also to use that as a roadmap when coming to operate on the patient. And same experience, fast diagnosis, same day. We usually reach conclusion and diagnosis and biopsy performed same day. And we've extended that also, just like Dr. Alcantara, to be used as a problem-solving tool. So we do about 1,000 contrast enhanced mammography a year. So really all variety of diagnostic setting.
Okay, that's quite a number, 1,000.
Yeah.
Probably more than MRIs done at many centers in a year. Now that's contrast enhanced mammography. Let's go on to talk a little bit about the ability to biopsy lesions that we see under contrast enhanced mammography. Dr. Balleyguier, prior to the ability to biopsy using contrast enhanced guidance, how would you biopsy breast lesions identified as CESM?
Yes, it's a good question. So before to have this solution, we did like we did on MRI, so second look ultrasound to find the lesions, and maybe in 30 to 50% of cases, if it's nodular lesion, we could find. Or also magnification views to find some small calcs, tiny calcs, which could be biopsied under a stereotactic view. But if we couldn't find any lesion, we performed an MRI, so an extra MRI after contrast mammography, and tried to biopsy a lesion under MRI guidance. So of course, it was quite complicated to add an additional examination such as MRI and also an MRI guided biopsy. So that's why we are very happy to have the solution now to make the biopsy under CSM.
And may I ask you, Dr. Balleyguier, how did your referring physicians, your surgeons, your internists, et cetera, and your patients find the addition of adding an MRI and possible MRI biopsy? Was that accepted okay, or was that a problem in having CESM widely implemented?
You mean if we had to perform an MRI after CSM?
Yes.
Yes, of course, it's an additional examination, so it isn't really a problem to make an additional examination. Even MRI, it's not find it so comfortable and quite anxiousness for patients. But the problem in many centers, and especially in our centers, besides the fact we have 2 MRI, but we could have delays to perform the MRI and to find quite a short delay between the diagnosis with CSM and the MRI guided biopsy. It could added maybe 3 weeks to more than 1 month to have the final diagnosis. And if it's a cancer, of course, to have to plan the visits, the clinician visits behind surgery, etc. It's is not as very good for patients, because you increase the anxiousness, and in some cases with very aggressive lesions, it could be a problem also. That's why that's better to do faster.
Right, I understand. I'm sure that when a patient is diagnosed with cancer, anxiety is something that's felt in all our practices around the world, very universal. So I get it. Dr. Kornecki, were you doing anything else differently from lesions that you identified as CESM prior to the ability to biopsy them under direct contrast enhanced guidance? How did you biopsy those?
Well, the default was always going with a second look ultrasound and biopsy under ultrasound if we could. The difficulties when we couldn't see that with ultrasound, probably about 20 or 30% of the cases that was the case. We were trying to find something if we can that is targetable for stereotactic guided biopsy on the mammogram exam, and if not, we were going for an MRI exam, just like Dr. Balleyguier.
Okay, wonderful. And you, Dr. Alcantara, anything to add to that?
Oh, actually, the difficulties here are very similar. We, as a team, always do our best to find an ultrasound or mammographic correlation that could help us to downgrade or to use as a target for a biopsy. In the end, some lesions went to MRI guided, of course, but scheduling this in my department, it's never an easy task, mainly due to the lack of MRI slots. Nevertheless, all of this process implies that a number of procedures done by ultrasound may end up being a negative or with uncorrelation with the initial virus classification. So demanding further evaluation, maybe additional biopsies, is slowing down the diagnostic process.
And a little bit of a challenging question is, what do you do with lesions that you just don't see on any other modality?
So far, those lesions, we are trying to perform the MRI guidance. If there's no way of finding a correlation with ultrasound or mammo, we were trying the MRI, but we were decreasing a lot of those indications, trying to do risky, and don't misunderstood, not risky for the patient, but taking the risk that I think that this is definitely the ultrasound correlation. So, and in the end, it was not. So it represents that the patient should be submitted to another procedure with MRI. So in the end, we are trying to delay the MRI, trying to find a correlation, because it's very difficult for us to schedule an MRI biopsy.
Has any of you experienced a CSM detected lesion that you tried, of course, second look ultrasound, of course, you try to see if there's any correlate at mammography, in which case you would do stereo, and you do your MR. Or even after you do your MR biopsy of what you think is the lesion, you put in your biopsy clip, it turns out not to be the lesion. What then? Or is that so infrequent that haven't encountered that in your practice? Is that only a theoretical? Would you do like a short-term follow-up contrast enhanced mammogram, just like you do on an MR lesion that you couldn't see on ultrasound prior to the ability to do MR biopsy? So yes. Maybe a 6-month follow-up? Dr. Alcantara, do you agree with that?
I agree with you. That in reality, more or less of the experience that we have with the MRI can be translated to the contrast mammo in the diagnostic setting. And I think now with the interventional setting, you can face some occasions where the lesion can disappear before the biopsy. And this happens sometimes with the MRI. And you also can face a reality where the biopsy is not in the perfect place. But in this case, you have to reconsider the degree of suspicion of the lesion and consider the possibility to schedule another procedure or a follow-up, as you said before, but never consider that a not very well targeted lesion could be considered negative by itself. It's very important, the correlation between modalities.
Okay. So all that's to say is really important and contributory clinically to be able to biopsy using contrast enhanced guidance, I think. So just as a reminder, remember to submit your questions through the question widget at the bottom of your computer screen. Let's go on to another question. For any of you panelists, what workflow improvements have you experienced by adding contrast enhanced directed guided biopsy to your practice? Let's start with Dr. Kornecki. How has your practice been affected by this ability?
Oh, we haven't much been affected, except for the fact that we still doing that under research. So the work is behind the scene with the consenting and recruiting and explaining that to the patient. Interestingly, we studied that now during COVID-19. So we were only allowed to offer that to patients who will be absolutely benefit from that. Otherwise, we couldn't conduct it. And so we managed to see how important this tool is for those patients. But other than that, it's just as simple as doing a stereotactic guided biopsy. It's very short. It takes us about 15 minutes to complete. And the scenario is very comfortable for the patients, unlike with MRI guided biopsy. MRI guided biopsy, we book an hour. Here, we finish everything in about probably all together 20 minutes. And the conversation, communication with the patients is much more friendly and comfortable for the patient.
That's an interesting point too. COVID-19, again, something affecting all of us around the world, that sort of the most efficient, right, methods of taking care of a lesion, working it up is obviously best. Dr. Balleyguier, anything to add to that?
Yes, we started our first biopsy, and I think we were the first team in last October, so October 19 for the first CSM guided biopsy. And we improved our speed now and our technique. So exactly as Dr. Kornecki said, it's quite fast, nearly 15 to 20 minutes. So that's much faster than an MRI. And also we had the impact of COVID-19 because during this period of COVID-19, we had also to review one of our MRI machine, and it was a machine where we performed the MR-guided biopsy. And our MRI was changing between March and June. So exactly during the period of the first wave of COVID-19 arrived. And so, of course, we had difficulties to block places in these situations to perform MRI-guided biopsy. So that was the occasion. That was much easier for us to schedule some cases, because even if our practice and the number of patients, especially for after high-risk screening, decreased a lot during this period, we had some cases we couldn't manage only with the second ultrasound. And so that's why we made more contrast biopsy during this period. And I'm quite happy that we first have our experience before to be trained and we are able to take in charge our patients.
Okay. And you, Dr. Alcantara, anything to add to that discussion?
Yes, we are also doing it in an investigation context that we will start in the same month, October 19. But in our setting, I observed that we have decreased severely the number of cases that went to MRI since we start with the contrast guided biopsy. As I said, those imaging workup that we were doing implied additional timing, and easily we were immersed in a 3 to 4 weeks process until achieving the final diagnostic. So having the possibility to use the CSM guidance to see those lesions that were unlikely or definitely not found on morphological imaging helped us to optimize our care pathway. It's a procedure, as my colleagues said before, that it's easy and fast as any traditional stereo guidance. So it's simply a stereotactic procedure.
Very wonderful. And certainly any tools that we can use during this pandemic time to help things in terms of our clinic and our patients, definitely welcomed. Let's go on to another question now. Dr. Kornecki, may I ask you, what is the number one benefit to your practice and to your patients that you see by having the ability to biopsy breast lesions using contrast-enhanced guidance?
Probably the ability to be able to manipulate the breast and pull the breast from the chest wall provides us some more flexibility so we can reach lesions that are fairly posterior that we couldn't reach with MRI-guided biopsy before, as well as lesions that are close to the chest, to the implants that we couldn't reach with MRI before. So what we saw so far, actually, we had 4 cases that we did the opposite. The patient had an MRI and we couldn't do the biopsy either because the patient said that she can no longer tolerate the procedure or because it was so close to the chest wall. And we managed to manipulate the breast in such a way that we did the biopsy under contrast-enhanced mammography. So this is a different aspect to that. It's not only lesions that's seen on initial contrast-enhanced mammography exam, but also lesions that's seen and detected initially on MRI exam can benefit from that.
Okay. Can you share with us, how do you position patients for those difficult to reach posterior lesions and near the chest wall and with the implants?
So we can, most of them probably will be seated, so we can pull the breast out and do the implant displaced view at the same time, which is a bit more difficult, or even turn them around if it's lateral to come from a closer approach. And then we can use the horizontal approach rather than vertical approach in order to go parallel and then just scratch the surface and biopsy the area. So I find that there is way more there are more options for manipulation and positioning the breast than we have with MRI. And we know that with MRI, there are some lesions that is very difficult to biopsy. And same thing with lesions, if they're close to the nipple, it's easier to get compression in this area. With MRI, it's a bit more tricky. So I find that this is actually a solution also work the opposite way to help MRI.
You mentioned seated. Is there a special chair? Do you think that the ability to recline or to place the patient decubitus, any of that is indicated or part of your work?
Yeah, they can either sit or lie on the side. And actually, that's one of the advantages, is the ability to communicate and to see the patients and talk to the patient. And the experience is way more comfortable than lying prone with the face, in a magnet coil. So it's definitely reported as being very tolerable and easy procedure by the patients. And by the same token, we save 3 spots of MRI for screening. That's the equivalent.
Any concerns or experience with vasovagal reactions?
We use the add-on, the seating unit. Usually we do that with the patient lying down. I think that I've seen probably 2 vasovagal reactions in 15 years. So this is how rare it was.
Okay. And Dr. Balleyguier, how about you? What would you say is the number one benefit to your practice, to your patients, with the ability to biopsy under direct contrast enhanced guidance?
I would say one very interesting point is the organization process. It's much easier to plan a biopsy appointment during your biopsy days in interventional, because usually you can have a visit during the weeks or maybe the day after. So it's much more difficult in many facilities to plan appointments for MR-guided biopsies. Because you are blocking the machine during at least 1 hour, so you don't perform any other MRI. So it's an interesting point. Also, examination is faster, so it's interesting for the patients. And as Dr. Kornecki said, you are just close to the patients, because after the localization process, it's exactly like a stereotactic procedure. And most of breast radiologists or interventional radiologists are used to interventional breast procedure. So that is not new. So if you are used to breast interpretation, so the training is quite fast. You have to know some small tricks, but it's very easy to be involved in this. And after it's interesting. And one also interesting point, you can switch very easily when you make your acquisition between the low energy view and the recon band view. So you have the morphologic view. So when you have the first pre-biopsy CSM, or like a normal mammo, so you will compare your views with the needle in place in the breast with the mammogram before the biopsy. So maybe you can have some area to target or to make the localization, maybe some tiny calcs you can see. Sometimes that's better to see that. And in MRI, you don't have these direct views of the breast during your examination. So also it's a new way to see the contrast between the anatomical views.
Okay, great. And I'll ask you the same questions about challenges and complications with this biopsy, particular vasovagal reactions, number one, or number two, do you ever see clip migration like you see with stereotactic biopsy?
After the localization with CSM targeting, so it's not exactly like vacuum biopsies. So you can have some clip migrations, of course, and also you have you can have also some vasovagal, but in our experience, we don't experience vasovagal reactions. So it's very rare. And also clip migration, that's quite rare also. But of course, you could have the possibility to see that. But I would say that maybe in MRI biopsy guidance, we do more sampling. Maybe in our institution, I don't know how my colleagues do that, but we do 12 to 18 biopsy samples. So the risk of hematoma and the risk of PIP migrations, it's higher. So maybe it could be difficulties we don't have with contrast mammography.
Okay, so certainly, yes, complications exist like any other procedure, but no more, and possibly probably less than with the other forms. So I'll move on now, Dr. Alcantara. You heard this discussion, the number one benefit. I'll ask you the same question. And why do you think this ability to biopsy using contrast-enhanced guidance is a critical piece of the care pathway?
Well, first, the ability to use the same mammographic environment that every breast radiologist are more than used to, it's a great advantage. And for sure, for me at least, the facility to schedule procedure, it's easier for me to add an extra biopsy with contrast than scheduling with MRI. Moreover, the features of the device, like the C-arm, the lateral arm, that allows us to use more horizontal approach. I use a lot. In my last review from the CSM guided biopsy cases, I did 85% of horizontal approach. I really like it because it's easier. So, and this helps us to approach lesions that we were not even, it was not feasible to achieve with MRI guidance before, like Dr. Kornecki mentioned. In the end, as Dr. Balleyguier said, it's not only a contrast guided mammo. You have the same equipment, the full pack with 2D, 3D, and contrast. So you can guide yourself with the 3D that includes the low energy image, but you also can go to tomo if you need it. As in my workflow, I do use the tomo for the clip confirmation after the biopsy.
That sounds very interesting, and it's very interesting to see how across the globe our practices are similar challenges, and perhaps that some of the extra benefits, like the ability to schedule on the same day, possibly depends on your practice, is particular value to some of our practices, but helps all of our practices in general. So thank you all very much for that discussion. So it sounds like that in terms of contrast-enhanced mammography, diagnostic indications, we ought to use it potentially for staging, problem solving, and perhaps even venturing into the neoadjuvant follow-up world, in particular with the functional aspects of contrast-enhanced mammography. And that until the ability to biopsy using contrast-enhanced guidance, we all did second look ultrasound, we try to correlate with mammogram, and then ultimately going to the MRI to find the lesion, all of which, of course, adds costs, time, and anxiety. And I appreciate Dr. Balleyguier's point that by having the ability to biopsy under contrast guidance, you can potentially have the same diagnostic radiologist fairly easily across all the spectrum, offering continuity of care, which in most circumstances is of benefit to the efficiency of the practice and to patient care. And then particularly during COVID-19, right, this special time in all our lives, that the ability to do as few exams to get as much answer as possible is of course so key to our patients. And the fact that with this biopsy is not just one modality, is morphology and function, and is the low energy, high energy, like a regular mammogram, as Dr. Alcantara just said. So thank you all very much for that discussion. Next up, something exciting. Dr. Alcantara has provided a case review from his first CESM biopsy, and he will take us through that patient case. Please feel free to submit questions you may have during his presentation in the question widget.
Hello, my name is Rodrigo Alcantara. I'm the head of breast imaging section of Hospital del Mar, Barcelona, and I'm going to present you our very first case of CSM-guided biopsy. Those are the images. It's a 61-year-old woman that was referred to us with a palpable lump in the right breast. As you can see here, in the low energy image, there's an irregular mass in the lower inner quadrant here that presents as a marked enhancement in the recombined image with an additional focus, both of them ultrasound biopsied. Histopathology reported an invasive ductal carcinoma of non-spatial time, HER2 positive. There's also a biopsy-proven axillary node affection. This is the low energy image of the left side. At the first sight, there's nothing wrong here, but when you look at the recombined image, you can see that there's an additional enhancing mass of 6 millimeters, brown-shaped, at 12 o'clock position. Also, you can see there's a minor focus just in front of it. We checked it on ultrasound. We thought to find the lesion, but it seemed that looking at the marker, we have mistake. As you can see, the marker does not correspond to the enhanced suspected finding, and also histopathology reports no valuable alterations. So we decide to ask for an MRI assessment in order to define the next step. With MRI, we confirm the extension of the right breast, already biopsied by ultrasound. On the other hand, the left clip marker did not match at all with the enhancing mass. The lesion is still suspicious due to a morphology enhancing pattern and restricted diffusion on ADC map. It happens that this MRI took place in the same week that we were starting with the CSM biopsy. We offered to the patient and she accepted. For the procedure, first of all, it's very important to review carefully the case for a better approach. For this case, we decide to go sitting with an horizontal needle approach. Here you can see the scout. This scout was obtained 2 minutes after the contrast administration. You have to wait 2 minutes until you compress the breast. And 2 minutes and 31 seconds after the contrast, which means 31 seconds after compressing the breast, you can see that the lesions, both of them, are perfectly centered in the middle of the field of view. So we carry on and proceed with the acquisition of the stereo pair. Like in CSM, each excision is composed of a low energy, similar to the normal MOMO, and a high energy, in this case a recombined image, and the radiologist can toggle with both of them in order to reliably target the lesion. It's now a matter of choosing the target that bears sweet and any of the preset needles that you have available on the workstation, and then send the coordinates to the gantry. If there's no warning, issue to be resolved. This is the pre-fire image that I've done after the anesthesia. We can see that the needle tip points exactly to the enhancing lesions. We don't use to acquire post-fire image, you know. The sampling time doesn't use to change, and the procedure like this could take around 12 to 16 minutes from the scout until the clip placement. Nevertheless, as you go beyond 10 minutes, it's unlikely that the enhancing information could be of value. So for the clip placement, I think it's not worth it to perform a CSM. So in this case, I prefer a 3D scout. With the 3D, I can confirm the exact correlation of the clip respect to the initial target with a similar dose than one single 2D scout.
This is the post-procedure mammography. In this post-procedure mammography, you can see that the clip is correctly positioned. The final histopathology report was of grade 2 invasive lobular carcinoma with some component of in situ lobular carcinoma, hormonal receptor positive, and HER2 negative. Remember that the contralateral was a HER2 ductal carcinoma. So patient went to neoadjuvant chemo with a complete response on the MRI, and after all, underwent a lumpectomy, a bilateral lumpectomy, and so far the patient's okay. Some information for the final conclusion: CSM-guided biopsy is very good and indicated to enhancing lesions that cannot be reliable sample under ultrasound or 2D, 3D guidance. But you have to take a look at that second look ultrasounds and ultrasound-guided biopsy of small, tiny lesions sometimes can lead to equivocal biopsies. This can slow down the diagnostic process and increase the anxiety of the patient. So CSM-guided biopsy has the potential to improve the targeting precision and decrease false negative and underestimation rates. Also, it's important to have the concept that it's a more affordable and faster alternative to MRI-guided biopsy. In the end of the day, decreasing those diagnostic times.
Okay, wow, that was a great case. Thank you for sharing. At this time, let's take some questions. I'm going to choose from the questions here and address it to each of the panelists. First question, a great technical question. What if you give the contrast for your contrast-enhanced mammography guided biopsy and your lesion is not in focus? Washed out, just not visible anymore. Have you had that experience? And then what do you do in that case?
I will go first. So actually, so far, there was only 2 or 3 cases that it was necessary 3 scouts to spot the lesion. Usually with 1 to 2 scouts you are more than able to find the exact correlation and the position of the lesion on the field of view. So the washout, we have to keep in mind that the washout on CSM, it's very different from MRI. You know, you have those compress and decompress cycles that it seems to decrease the washout. My experience is that also we maybe have some kinetics difference between the gadolinium and the iodinate contrast media, but the reality is that more often I have a correlation, a contrast enhancing lesion in 7 to 8 minutes. So it's more than time for you to find a correlation. So it's not, I think that it's not difficult for you. If there's a lesion that enhances, you should find it. The other question is that if the lesion disappeared, that can happen with the CSM, with MRI also.
Okay. And maybe Dr. Kornecki now. What is your experience in biopsy enhancement that correlates to calcifications at mammography?
Well, if I see the calcifications very well, I don't need the CSM biopsy, but sometimes they're very faint. And sometimes we know from the contrast enhanced mammography that there is an area that it enhances more than the original calcification. So maybe this area is more associated with the invasive component rather than DCIS, and we want to obviously biopsy this one. Then we will give contrast, so our biopsy will yield the best results to impact the patient care and treatment.
Okay. And I know, Dr. Kornecki, you spoke about implant patients. One of the audience asked, have you done any CSM biopsy with implant patients? Tell us about that.
Yeah, we did so far 2 patients with implants, and it was very posterior and close to the implant. Was not. We tried on MRI-guided biopsy, and we couldn't do that on MRI-guided biopsy. So we managed to position the patient in a way that we displaced the implants from our field of view, and it was actually very easy to do.
Okay. And Dr. Balleyguier, you spoke about the potential of scheduling on the same day or the continuity of the care. One of the questions is, what's your feedback from your technologist team? Do they like this method of biopsy?
Yes, they like, because for them it's not very different as they know in stereotactic biopsies. Usually the technologists who are scheduled in the breast unit are used to interventional and diagnostic mammography. So after a short training, after 2 patients, I would say, with a referee technologist, they were able to do alone without any failure the procedure. So I would say the only difference is you have to go very fast if you don't want to lose time. So your table, the radiologist must be dressed immediately in a good way, and you have to be quite used to work fast if you want to do everything in a fast way, in a safe way. So everything must be scheduled, everything must be prepared, the needle, the clip, etc. And after, it's not really different for stereotactic biopsy.
And continuing on that, Dr. Balleyguier, any experience about the level of compression difference between CSM and kind of more traditional mammography, if you will?
Yes, that's a good question, because at the beginning we had to make a little bit our experience, because it was not published, and we adapted our technique. So at the beginning I wanted to press very little, maybe more little than a normal contrast mammography, to be sure to have enough contrast to see the lesion. And finally, that was you need a compression, of course, not too much. So usually we compress until 3 to 5 decanewton. So, but it's usually that we do with the normal contrast mammography, but you don't have to do less, you don't have to do more. And also at the beginning, we wanted to go faster. So maybe normally we wait 2 minutes after contrast injection in order to see enough contrast to start the procedure. At the beginning of our experience, we wanted to go faster. And finally, we realized maybe the contrast was not so high. So that's why I will advise to do exactly like we do normally. So you inject as the breast is not compressed. So at the beginning, the patients must be installed like the normal procedure. We made the scoot views to see where we could be the lesions with compression. Then we decompressed, we inject, we wait really 2 minutes. Then we compress the same area lightly, so between 3 to 5 downs. And then at these times, you make your low energy and recon band view, so you see the lesion and you start your procedure. Okay. But that's important that injection of contrast must be on a non-compressed breast.
Great, thank you. And Dr. Alcantara, has your referring physicians expressed any concern about the use of contrast-enhanced guided biopsy versus the traditional quote-unquote gold standard of using MRI?
Not really, definitely not, because as I said before, the contrast guided, it represents to us an improvement in the healthcare timing. So they are really, they welcome this initiative in order to benefit the patients being faster. It was a really issue for us, all the process of going to MRI and MRI biopsy. So it's something that it was very well received there. Okay. We are a very good team, so they are happy with that.
And Dr. Alcantara, any tips for us in your experience about the anesthesia to reduce the does it reduce enhancement visibility? Like the amount of can you inject?
In my practice, I realized that, of course, that the anesthesia comes after the targeting. So your first excision, the scout and the stereo pair, they are with no anesthesia because it's previously just sending the coordinates to the equipment. So it's not going to spoil you to see because you haven't used anesthesia so far. So you have already sent the target. What I do recommend is that do not use lots of anesthesia in the initial procedure before putting the target, the needle inside. Because as we know from tomobiopsy or for stereo biopsy, if you use lots of anesthesia, you can displace a little bit your target. And in this case also, if you produce an hematoma, in that case, you can displace and maybe blur your lesion, but it never happens to me because I use the necessary anesthesia to obtain the blockage. So the key here, it's precision, not volume.
Okay. Do you ever have to give contrast twice for the same biopsy procedure, like a resection?
No, I did use once, was to perform a contrast biopsy the same day than the contrast guided, the diagnostic contrast mammo. So I did a contrast mammo. I had the slot for a contrast biopsy. So it was almost 1 hour and a half, 2 hours later. The ACR contrast media do not state that you cannot overlap contrasts. We do in the emergency radiology actually. So I did the same procedure 2 hours later, and it ended well. The patient was concordant with the procedure, and the result, the final result, was invasive ductal carcinoma. So it was everything very well wrapped.
And I know, Dr. Alcantara, you spoke specifically about neoadjuvant therapy patients. Do you find that you have to wait more than the traditional 2 minutes before imaging just because of the presumably poor vascularization after the administration of neoadjuvant chemo?
What happened here is that there are different protocols, acquisition protocols. The first 2 minutes, they are mandatory. It's in the beginning of the technique from works from Gustave Roussy Institute, trying and experimenting the timing where you should begin administrate with the contrast administration before compressing the breast and doing the mammo. So the 2 minutes is very good. What I do differently is that after the 4 standard views, I always do an additional lateral view of this breast, or the breast that I'm looking for. So it's kind of looking at a late enhancement, you know? So I have different phases of the same image, but with different aspects, because one is a CC view, another is an MLO, another one, the last one, it's a lateral view.
Great, thank you. And I'll ask the very last question to Dr. Kornecki, and it's a big question. And the question is really, we talked a lot about diagnostic indications, which are wonderful, a discussion. Do you see a future in screening, maybe the dense-breasted women or the high-risk groups?
Yes, I do. I do see a strong future with screening. Probably we wouldn't use it for the pure high risk where we want to minimize radiation and we want the most accuracy, but definitely as a supplementary tool and as a replacement for ultrasound supplementary screening tool. It's easier, more accurate, and was published so far that there are more cancer detection. I think the last publication from Sloan Kettering, they found 15 cases in the cancer detection in 1,000, which is a lot.
And I said that was the last question, but the very last question, because one of the audience asked about radiation. If you had a choice between contrast enhanced mammography, guided biopsy versus tomo-guided biopsy, does the radiation dose affect your decision, and which would you choose and why?
The radiation difference is minimal, if anything. There is a radiation dose is to begin with decreased when we're doing contrast enhanced biopsy because we don't need the same resolution that we do for microcalcifications to be seen. So this is not the same radiation dose that is usually associated with stereotactic guided biopsy, and therefore there is no issue. And may I just add one thing to one of the questions that came up with the washout?
Yes, we're going to do it very quickly then.
Yeah, very quickly. Remember that we use the lower energy view, so we do have the landmarks to go by. So even if the contrast starts to wash out as we do the biopsy, and we know that from MRI, we can use the lower energy view landmark to make sure that we're still within the same place.
Okay, thank you. Thank you all very, very much. That just about wrap things up. Thank you, panelists. And of course, thank you all very much, our audience, for joining us as we work together as a team for novel modalities to help all our patients. I will now turn the webinar over to Catherine Leslie from GE Healthcare for some final words. And please feel free to join the After Hours event if you like to speak with someone further about Serena Bright.
As you heard from our panelists, Serena Bright is a positive step forward in the personalized breast care journey. This has been a true partnership with our panelists, and we say a very sincere thank you for your feedback and commitment to ensuring this is a solution for you as clinicians will continue to leverage and improve. I would also like to thank our internal teams, engineering, clinical leaders, finance, regulatory and region leaders for all their hard work and support. Thank you all for joining us today. Our virtual auditorium will be available for you or colleagues who were unable to attend today for the rest of the week. And we encourage you to explore the materials. If you would like to speak up with our local representative, please fill out the contact form and we will get back to you quickly. Have a great rest of your day.